Hi, everyone. Thank you for joining our webinar on insights into infertility. We're going to wait until a few more people join, and then we'll have the fertility specialist, Dr. Hal Danzer, and our acupuncturist, Dr. Jen Shulman, go into today's presentation. All righty, it looks like we're ready to start the presentation. So here we go.
Good afternoon. Thanks for joining us. I'm Dr. Hal Danzer. I'm one of the co-founders of SCRC. We've been here for 25 years. Just had our 25th anniversary, and Dr. Suri and I have built this clinic over the past few years, and we've always had our eye on the horizon in terms of the very best in technology to offer our patients the very best pregnancy rates with personalized care, which is, I think, so important in terms of relationship between the patients and the physician going through the process of fertility treatments. Mentions down here the grandson of a midwife. My grandmother lived in rural Montana in the late 1800s and used to ride horseback to help women with their deliveries. And you look at the amount of technology that she had in those days, what we have today in just 2 generations is truly amazing. And certainly that's reflected in the quality of the pregnancy rates that we have today in treating patients with infertility issues.
I'm Jen Shulman, the acupuncturist at SCRC. I've been here almost 4 years and been in practice for 15. I have a clinical doctorate in integrative reproductive medicine as well as a board certification. I'm here a few days a week. I try to be available on request for a day of embryo transfers. I think we say a little bit more on the next slide too. Back to you, Dr. Danzer.
Yeah, we talked about 25 years. We're one of the senior fertility programs in Southern California. And we talked about state-of-the-art embryology laboratory, which is really the heart of a fertility center in terms of how they process sperm and how they create and grow embryos, particularly to day 5, a 100-cell embryo. Our laboratory is really known for the ability to grow and test embryos. We have an on-site surgery center for all those surgical treatments that are necessary for fertility. Our initial location was here in Beverly Hills, but we've had Santa Barbara for over 15 years and Pasadena for the last 4 or 5 years. Again, our focus has been to offer the very best in terms of fertility care for our patients. And then you say, well, what makes a premier laboratory and surgery center? It has a lot to do with the embryologists and how they're trained. Embryologists are critical in terms of the quality of what happens in the laboratory. We have almost a dozen embryologists. We're very busy. And that allows us to do what they call double witnessing. Every step of fertility treatment, there's two sets of eyes on the embryos and the eggs that might be freezing. We talk about vitrification, which is the new modality or the most recent modality for freezing eggs. And thaw rates for women who freeze their eggs is close to 90%. It wasn't that good a few years ago, but now that technology is very good. And the predictability of having high quality eggs after the thaw, which allows you to make very high quality embryos. And as we talk about this blastocyst biopsy, you have to be able to grow an embryo for about 5 to 6 days to get to a 100-cell stage. and then take a few cells which go to the genetics lab to test for the 23 chromosome pairs. Included in that is X and Y chromosome. There are couples that have 3 boys, 1 a girl, or vice versa. But once we have a genetically tested embryo, the pregnancy rates are close to 70+% with the transfer of single embryo. So today we're not transferring multiple embryos because we know the potential of a given embryo once it's genetically tested. And also it lowers the miscarriage rate. We know in the days when we didn't have the testing for embryos, miscarriage rates are 15–20%, just like they are in the general population. But that drops in half when you test embryos. We know that the embryos that miscarry are the small chromosome duplications. 21 is the Down syndrome. You don't transfer that. 22, 18, 17 duplication of chromosomes, again, causes miscarriage rate. So miscarriage rates are maybe 8% with present genetic testing. We have a new technology in our laboratory called an embryoscope. And essentially, it's imaging every few minutes during the day, looking at how an embryo divides in its early stages, 2, 4, 8, or asymmetric development, 1 to 3, 2 to 5. The ones that are asymmetric do not have a pregnancy rate equal to the ones that go 2, 4, 8. So it's a way of ranking embryos so that you're testing the best embryos with the best potential first. So it cuts down the time to successful pregnancy. So again, it's a technology that requires a lot of expertise and embryologists, and we're very happy to offer that very newest technology to our patients. We're one of the few laboratories in the Southern California, the area that has embryoscope. So today's discussion, we're going to talk about the holistic approach, which is very important, and the benefits of acupuncture. And then we'll go into some of the other factors involved in fertility and, testing and what the treatment options are. So we'll pass it back to Jen. And I still remember when I had the times I've had acupuncture, I've had this wonderful rested feeling afterwards. The body was peaceful. And, she'll tell you why that happens.
It's so funny, sometimes patients say, how should I expect to feel when I go home that first night after getting acupuncture? And the truth is, most of my patients say that they get the best night of sleep they've had in a while. And patients who use an Apple Watch or a Fitbit or a Whoop, some sort of device to track their sleep, will often report back in that they will get anywhere from 20 to 30 minutes more of deep sleep than they normally do. Can we go to the next slide, please? Okay, so what I do here at the clinic is I help patients at all different stages of where they are on their fertility journey. So sometimes I work with couples who've come in and they've done testing with the doctor and a consultation, but they're not ready to do an IUI or IVF, and they just want to do timed intercourse with a little bit of monitoring. So I work with patients and do a very timed acupuncture treatment. So certain points for the menstrual phase, the follicular phase, the ovulatory phase, and the luteal phase. So a 4-phase treatment plan. I'll work with patients who do IUIs, and then I'll also work with patients leading up to their retrieval. And sometimes, if I'm lucky, I get patients 3 months before they do their first retrieval, and then I get to be with them in a whole oogenesis cycle, which is about 90 days. So it's great because I'm not just sending blood flow, because when you insert the needle, it increases nitric oxide in the body, which increases the flow of blood, which then increases oxygen. So it's like a food delivery system. Like I help be the caterer to the eggs inside your ovaries. So if I get a start 90 days before, I get to be working on them and feeding them nutrition before you start your retrieval. Acupuncture helps with the HPO axis. So it's essentially helping your brain talk to your ovaries and get everybody talking to each other correctly. They can show that acupuncture relieves stress by resetting the autonomic nervous system, getting you out of fight or flight and into a relaxed state. And that is maybe like 30 or 40% of my patients will take a nap while they're on the table. Now, I don't know if it's everybody's really busy and it's dark and you finally get a chance to relax away from your screen, or it's the acupuncture and it's me. I will help patients throughout their retrieval with medication side effects. I will do the nutritional counseling. And sometimes what I do is I help the patient formulate the language they need to ask their doctor what question it is that they have. Because I know when you get your doctor on the phone, that time feels so precious and you don't always have your questions written down, or you're not quite sure how to ask what it is that you need. And sometimes while I'm putting the needles in, they'll say, I really want to ask the doctor this, but I don't know how to ask that question. And I help them find that language so then they have a better communication style with their doctor. For embryo transfer, there's been quite a bit of research. There was a seminal study about 20 years ago on fresh transfers that showed an increased pregnancy rate by a little over 16%. And then a new study in fertility and sterility came out over this past summer, and it showed acupuncture increased live birth rate by 13% and reduced biochemical pregnancies 42%, which is pretty cool. So I mentioned acupuncture increases blood flow for your follicles, but that same effect works for your uterine lining. For patients who are not actively in a cycle and they're doing more timed intercourse, it helps regulate the menstrual cycle. So what that looks like is, if you're the type of patient where your cycle is only 24 days, and your luteal phase is only 8 days, often what will happen is my patients will go from a 24-day cycle to a 27-day cycle, and that luteal phase will stretch out and give a little bit more time for implantation. My dissertation topic was on the treatment of acupuncture for primary dysmenorrhea. So I would say every patient reports a decrease in menstrual cramps when they start doing acupuncture, even if that's not the reason that they came in. And here at SCRC, we are actually doing a study on the treatment of hormonal headaches during IVF egg stimulation with acupuncture. So acupuncture is great for hormonal headaches. And then I will often see most of my patients that I'm working with through the first trimester. So usually what that looks like is acupuncture once a week through week 13. And then once they graduate to the second trimester, they often see me once a month. Patients definitely have reported decreased emotional stress. I think one of the things I've been told more recently is my patients really feel seen. I think that I use a lot of humor in my approach. I have a lot of candor. I like to talk about the relationship my patient may have with their partner and give them an opportunity to talk about. What can happen for couples is this can be really private, and the fertility or infertility is not something they may feel comfortable talking about with their friends or work colleagues, or even their doctor. And there's the intimacy of the relationship. Sometimes it's nice to have somebody to say, yes, it's very normal that now you've been doing IVF and you did a retrieval and then you did a hysteroscopy and now you're preparing for transfer, and somehow you haven't had sexual relations with your significant other in 3 months, which feels so contrary for the baby making process, and you have nobody to talk about that. And we'll talk about it because I'm here, I'm your girl. We're going to talk about things. Deep breathing. Patients will say that if they came in and they're stressed and they feel like their breath is up here in their neck and their top of their chest, they can finally sink deeply into a deep diaphragmatic breath. The better sleep, which I mentioned earlier. Like all of us, anytime we can put the screen down, I think we become a little bit more human. Usually just for first-time patients, they'll experience what's called the acupuncture high. or people who haven't had it in a long time. And that is because the stimulation of the needles does release endorphins in your body. Okay, benefits of nutrition for fertility. Vitamins and nutrients are linked to positive effects on fertility. This can be very general, or this can be very specific patient by patient. The Mediterranean diet has been shown in a lot of research to be the right move. I like to recommend for patients who are vegetarian or vegan to lean a little bit more towards that 90% predominantly plant-based. If you can manage to eat eggs, I'd love if you would eat eggs for the choline and the animal protein and the healthy cholesterol. We want our patients, what happens with the supplements that your doctor will prescribe. If you're watching this webinar now, I would start now. So you would take your prenatal with folate or folic acid. You would take usually a fish oil. You would take CoQ10. We often recommend a dose of 200 milligrams 3 times a day. Start everything now. Don't wait for your first appointment. As far as nutrition goes, I'm kind of a label reader. And if you don't know what you're reading, don't eat it. It's the whole point of the whole food diet. So you're going to want to eat a salad where you actually know what the ingredients are, or cooked vegetables. Chinese medicine is very into a lot of warm cooked vegetables, warm cooked food, not a lot of raw. We want to nourish the body and not make it work too hard to digest things that are raw, or warm the body up to digest foods that are cold. Love fish, small bone fish, avocados, nuts, seeds. A lot of times patients ask about seed cycling. I always say, absolutely do it. I'm very into it. I don't want to be in charge of telling you which seed to eat at the right time, but there are plenty of templates. Let's go to the next slide. Here we go, prenatal. A lot of times patients ask about brands. You can talk to your doctor or your OBGYN that you have at home. Just make sure that they have the correct amount of folate in it. CoQ10, I went over the dose. Vitamin D, will run your vitamin D levels when you come in here. I actually was at a fertility symposium about a month ago, and the doctors there were saying that they really are looking to see vitamin D levels over 40 in patients. So we'll check that here, and we'll tell you, do you need to take 1,000 vitamin D IUI or 5,000? And so your doctor will check in with you after they do all of your preliminary blood work. And we do that to help with your egg quality, but also to decrease the chance of miscarriage. Oh, alcohol. I personally love to go wine tasting and drink wine, and my patients will very candidly say, like, okay, I'm going to do a retrieval. Can I have a cocktail? And I always say, this is very expensive, and this time in your life is very valuable for you to be doing this. Just now is not the moment. You can just wait 2 weeks. So I just say, if you're doing a retrieval or you're doing a transfer, just try to not drink at all. As far as cannabis, marijuana, that is a no all the time. And smoking, we already know affects egg quality. It's low birth weight, reduced egg count. And this goes for men and women. So I don't want people to feel that their partner doesn't have a responsibility in this as well. I really recommend that for men, they do not smoke anything at all. Sorry. Back to you, Dr. Danzer.
Thank you, Jen. Well, it's getting the body in harmony when you get ready to get pregnant. I think that's nutrition, exercise, stress reduction, getting the body in harmony helps your physiology, helps you do the very best that you can in terms of maximizing your chance of success in a given cycle. Changes your life a little bit, but it's a good thing to do in terms of later life, longevity. I think good nutrition, exercise, and stress reduction are 3 things that have been continually identified as helpful in terms of a good life, mentally and physically. So for there's the definition of infertility for patients, again, under 35, and we'll come back to the age issue. If you've been trying for a year, that's 12 eggs. If you're having a period every month, you probably release 12 eggs if you're having regular cycles. And we know that after a year of trying and you haven't conceived, then the probability of getting pregnant per cycle after that is 2, maybe 4% from many studies. So there's something going on that is preventing that. And we'll tell you about the testing. Again, for patients over 35 years of age, the bigger issue is decrease in egg reserve. And you look at that graph in age years and fertility females, you see how the graph drops off in terms of the percentage of eggs that are genetically balanced. Sperm are made every day. They don't have the same kind of age issues. They didn't start till 45, but it starts at 35 on average for women. And once you begin to diminish your egg supply, the quality of the eggs change. And then we talked about the percentage of genetically good eggs, and genetics is such a huge part of fertility. So women are born with 1 million eggs. By the time puberty occurs, they're down to about 50,000. We don't know why so many of the eggs are lost before puberty, but somebody designed the system to do that. But some women are born with less eggs, or they lose them more quickly. We're not sure. But as you diminish that reserve, again, the quality genetically of the eggs does change. And that's why age is so important in terms of assessing one's what we call egg reserve with an ultrasound and a blood test. So evaluation starts out with a medical history, a family history in terms of illnesses, connective tissue diseases, rheumatoid arthritis, lupus, inflammation disorders, endometriosis can run in the family. These are genetic disorders that can go from mother to daughter, father to daughter. Same thing for men. So review of the history, and then we come to the laboratory, and here's a basal follicle count. The ultrasound shows what they describe as a chocolate chip cookie. Each of those follicles are about 5 millimeters, have immature eggs. So this is an ultrasound day 2 or 3 of the cycle, just after the menstrual period starts. And this ovary recruits maybe 5 to 10 follicles on each ovary. But out of that group, one is going to be selected out as the dominant follicle. Humans only release 1 egg. They don't have litters. But the unfortunate thing is that the other 9 eggs from this ovary are kind of wasted. They dissolve and go away. And then you start with a new group of eggs the next cycle. So there's this loss of eggs and embryos, or potential for embryos, as a woman goes on age-wise. And you look at this AMH reading, it's called anti-Müllerian hormone, and all the thousands of follicles in the ovary produce a little bit of this AMH. And as the AMH lowers, we became more concerned about the egg reserve and how aggressive to be with treatments for fertility. So here's the testing for the man. It's relatively easy for him. It's a semen analysis, and is done after just a couple of days of abstinence. You know, the sperm recover very quickly in terms of their numbers after one ejaculation. The volume, they look at the concentration. You want to have about 20 million sperm. And they look at the motility. About half of them swim well. In morphology, a lot of them are not normal shaped. But if you have a good count and a good motility, we don't worry about the morphology too much because you have plenty of well-formed sperm. And they say maybe 25% of infertility is from the male. That may vary from study to study. But if you look to the right, you look at all the different shapes of sperm, there's only maybe 1 in 5, 20% of sperm that have good motility or are shaped normally, that have the potential to fertilize an egg. So a system that's making millions of sperm a day, biologically, there's only a small percentage that are going to be normal. But when we do intrauterine insemination, where you can do what they call a wash or a swim up, you're picking out that 20% of the sperm that have the best motility and the best shape. And then that drop of concentrated sperm can be placed in the uterus. It's like a pap test. It's very simple to do. And from all the studies, fertility treatments, intrauterine insemination seems to enhance pregnancy rates, even for men that have really high pregnancy or really high sperm counts. So intrauterine insemination, and again, if you look at this graph, in a natural cycle, if you're in that infertility category, your chance of getting pregnant per cycle is 2 to 5%. And when they sell natural cycles, what's the chance of anybody getting pregnant? It's about 25% per cycle. If you're mid-30s and lower. But after a year of trying, there's that 15 to 20% of couples that are not pregnant. And again, it has to do with either male factors or female factors. So we talked about couples that come to us and they've been trying to get pregnant for over a year, and they're ovulating, they're having regular cycles, and the sperm count's normal. We may have done a X-ray to look at the tubes if that's indicated. But you look at a natural cycle with insemination, it almost triples the pregnancy rates per cycle. Clomiphene, an oral fertility agent, and Femara kind of boosted up to about 10% per cycle. You say, well, that isn't huge, but again, anybody's chance of getting pregnant is about 25% when they first begin to attempt pregnancy. So using Clomid with insemination can bring it to 10 or 12%. And the guidelines today are, if everything tests normal, is to do 4 to 5 Clomid cycles. And again, if you're not pregnant, you can add some injectable follicle stimulating hormone and again, boost it a few percent, but that's only for a few cycles. But also that gonadotropin injection kind of tells you what the ovary can do if you're going to move on to in vitro fertilization. So it's a progress of using simpler technologies to more complicated, and then those couples that are not successful then become candidates for in vitro fertilization. And the big advantage of IVF is you can get 12 or a dozen or 15 or 20 eggs. So you get a year, maybe 2 years of eggs into one test tube. And then the sperm are actually injected into the egg most of the time, which kind of guarantees fertilization. Because if you've been trying for a year, we don't have any technology to know, did any of those eggs fertilize? Did they not get together? Did the fallopian tubes function well? Did they not pick up the egg, carry the embryo? Those are technologies we just don't have today. So what's IUI? Again, along with Clomid or letrozole, those are things that enhance the quality of the ovulation, the development of the egg, the maturation of the egg. And then you look at ultrasound, probably day 10 or 12, and you look at the follicle size. And also you do home predictor kits. We usually do what they call a trigger, where we give a injection of luteinizing hormone that releases the egg probably the next day at 12 to 36 hours. And again, the IUI is like a pap test. It literally takes 5 minutes. And then our pregnancy test is 2 weeks later. And so IUIs with Clomid traditionally have been done for about 4 to 5 cycles. For those couples that aren't pregnant, then they graduate usually to IVF. So here's IVF treatment schedule, and it's the same for women that are going to freeze their eggs. We do a baseline ultrasound, and many times we'll go on birth control pills to get the ovary quiet, to synchronize the follicles. And then you stop the pill after 2 weeks. The ovary is quiet, and then you start injections of natural follicle stimulating hormone. And FSH injection has been used for 40 years almost. Tens of millions of women have done those cycles, and there's no breast cancer, there's no ovary cancer, and there's no early menopause. You're just bringing to maturation, would be wasted eggs. So, and it's a natural molecule, so it only does one thing in the body, and that's to stimulate egg maturation. If you get a lot of eggs, if you get a lot of follicles, which make estrogen, A lot of women who experience bloating as they get the last few days. And the estrogen being 200 when you have one egg is 2,000 when you have 10 eggs. But that's the main side effect. And it takes about 12 days. You come in for ultrasound and blood test day 4, 6, 8, and 10. And by 10 days, most of the time you're ready for that, what they call trigger shot, and then retrieve the eggs about 36 hours later. Retrieval is all done with ultrasound today. It's just like when you draw blood, the lateral vaginal wall is about the thickness of the skin. The needle only goes, this diagram is misleading. The ovary is right next to the vaginal wall, and it's done with a little bit of propofol. It's not a full general anesthesia because you don't breathe on your own. Turn off the propofol, you wake up in 5 minutes, and you're out the door in an hour. Most people take Tylenol. It's not a painful procedure afterwards for most. And again, it's very safe. Infection or bleeding is way less than 1%. But again, you put a needle, you can see on the right, those 5 millimeter follicles after 10 or 12 days of injections of follicle stimulator. Now they're up to 20 or 22 millimeters. Now they have a mature egg inside of each of those follicles. And that last diagram shows the needle. It just goes, like I say, a half inch into the follicle, and you aspirate the fluid. The fluid is collected in a tube, and then it's passed into the next room where the embryologist then takes the eggs from the fluid. And again, it takes maybe 15, 20 minutes for an egg retrieval. And again, afterwards, most people do well with just Tylenol. So it's not, there's no incisions or anything else. So here's in the laboratory, you can see an egg there with this needle coming close to it. And the egg is like jelly. And so they're injecting a single sperm into the egg. You can see the sperm and the size of it. And it's the genetic piece in the sperm that actually fertilizes the egg. It does not damage the egg. Imprinting disorders are like 1 in 5 or 10,000. But you look at fertilization rates about 75% when you do intracellular sperm injection. And here's a little movie of how an embryo divides: 2, 4, 8 cells, up to 100 cells. And again, looking with the embryoscope, you see how this division occurs and how symmetrical these cells grow. And that's important. Now you're out to day 5 with about 100 cells. And this is the point where they can take a couple of cells around the periphery, not the fetal cells from in between, and send those off for genetic testing. The embryo then is frozen. And once the embryo is at 100 cell stage, which we see coming up again, the freeze and thaw rate is like 98%. So that technology is very good. You don't lose embryos with the freeze and the thaw, but allows for the genetic testing. Again, you've seen that diagram where they just take a few of the placental cells, not the fetal cells. Does not damage the embryo. And, we know that with genetic testing, a normal embryo with all 23 chromosome pairs, the pregnancy rate's running close to 70% plus today, with a very low miscarriage rate of 8%. That's kind of how the technology has evolved over the past 10, 15 years with genetic testing of embryos, which has been truly a boon. Increased pregnancy rates, dramatically less miscarriage rates. Here's our 4 doctors at Santa Barbara and here in Beverly Hills. So we're going to talk about promotions. I don't know if anybody has any questions for a moment or two. We'd be happy to answer any questions that we can.
Yeah, so we're running a few promotions this month. We have the Central Coast IVF package that we run in our Santa Barbara office. And then for April, National Infertility Awareness Month, we are running 2 different promotions: $1,200 off an egg freezing cycle and $2,000 off of an IVF cycle. And these are for all new patients.
an egg-free cycle today, it's packaged about what, 7,900. Medications run $2,500, $3,000. It kind of rounds out to about 10,000. So that's a nice decrease.
We also have a special offer for everyone who has joined our webinar today. So when you go to our website and fill out our consultation form, you can use the code webinar50 for 50% off your consultation. And then at this time, the doctors will be answering any questions that you have. So please use the Q&A box at the bottom of your screen. We have a question. This first one says, if a female is 45 years old and AMH is 0.13, can she do egg freezing, and how much is the success rate?
Yeah, most of the egg freezing data came from women under 35. Certainly we see many patients between 35 and 40 today. However, 40, there's not a lot of data. We think as you get to mid-40, the chance of getting pregnant with IVF runs about 2 to maybe 5% if they have a really large reserve. If the AMH is less than 1, that kind of signals a low reserve. And of course, you'd have to look at the basal follicle count. But if the follicle count's less than 7 or 8 eggs, again, I think that usually translates into a pregnancy rate that's kind of in that 2% range, which is not encouraging for people to move forward to do that. Some do. Again, you offer for patients to look at donor eggs. We know we transfer embryos for women up into their late 40s. The uterus doesn't not have too much age effect because with a period every month, the lining is kind of regenerated. But it's hard to make that transition emotionally from your own eggs to a donor egg. But again, you have to enter the cycle of egg freeze in your mid-40s with the feeling that it may not be successful. And, the emotional investment and the financial investment, has to take into consideration in making that decision to do the cycle or not. But I think meeting with the doctor and discussing your individual situation is always helpful to get some closure on that issue. Absolutely.
Dr. Danzer, this question says, is there an age cutoff for freezing embryos?
Embryos. I think there are many clinics that strongly discourage women from making embryos after age 45, because again, the pregnancy rates run 2% or less. There are a few patients that have a large reserve and again, feel that they need to invest emotionally and into that and financially. That's an individual decision. But embryos, if you test embryos at 44, 45, it's maybe 1 in 8 or 10 that's going to be genetically normal. So you'd have to do usually multiple cycles to generate multiple embryos for genetic testing. And again, maybe 1 in 8 or 10 would be normal. So it's truly a commitment, and again, emotionally and financially.
We have a nutrition question. So do you suggest going gluten-free while trying to get pregnant? And if you have PCOS, is there a diet you suggest following?
I can do this one, and then Dr. Danzer, if you'd want to add on to what I would say. When you lean in more towards the Mediterranean diet, you will tend to eat more of a gluten-free diet anyway. I personally don't think every patient needs to be gluten-free. And I know that PCOS patients often can do well on a keto diet, but I caution you for the purpose of embryo formation and egg freezing to not do a straight keto diet. I don't want your ovaries to think that you are actually in starvation mode and your body needs to expend its resources otherwise. So I would just, a diet with really good fat and healthy protein and light on the carbs. What do you think, Dr. Danzer?
Yeah, I think there's a lot of good science that indicates that the Mediterranean diet, particularly with olive oil and so on, adds to good health and longevity. Unfortunately, some minister brought us with a lot of carbs and a lot of sugars and carbonated drinks. I think you really have to look at your life and say, it's time to move away from those things and really look at good nutrition because it's so important in terms of preventing predispositions to inflammatory process, which endometriosis or cardiac disease, rheumatoid factors, all of those are conditions can be aggravated with the wrong kind of diet. And it's a big decision that we have to make to switch our dietary issues. But I think it's really, really important, not only for fertility, but for your general health in your life.
And I want to say too, like when you make these conscious decisions to change your diet and put more vegetables on your plate, like everything we're doing here is the journey to parenthood. And as a parent, you're going to be wanting your children to eat a lot of fruits and vegetables. So the time to do this stuff is now, and get in the habit so that you're already that mom or dad who shows up and is like, no, it's definitely a broccoli and Brussels sprout night. We are not having pasta again.
I have another question. This one is about a weight requirement in order to do IUI or IVF. Is there flexibility with BMI requirements?
I think there's a multitude of science that certainly in the fertility field that, BMIs over 35, pregnancy complications are multiples of what they would be if you're under 30. And we strongly encourage people to not have an embryo transfer or get pregnant if their BMI is over 30. Again, now Ozempic and those products have come into the field. I think we don't know long term, but they seem to be safe. There was an FDA report that people seem to stay with Ozempic and they don't stop the medication like so many others. And it's everyone's, I want to say, body machine, what you do nutritionally and how you lose or gain weight is different. It has to be customized. I think you need help to do that, either a nutritionist or someone that can outline calories in and calories out. But I think we encourage everyone to get to a BMI of 30 or less to have a healthier pregnancy. You don't want to risk a preterm labor or high blood pressure and have to deliver early, complications for your offspring. You just don't want to have that. And I think all the science is beginning to say that BMIs are important.
Okay, this question is for Dr. Jen. Should I be getting acupuncture 3 times a week prior to starting the cycle and during, or is there a recommended amount per week?
Okay, that might be practitioner to practitioner. So sort of, I don't want to step on somebody else's treatment protocol, but I usually would only advise somebody come in 3 times a week if they were older, somebody with diminished ovarian reserve, or a patient who has a known history of poor genetic quality or poor embryo formation outcome. So I have some, young women who freeze eggs in my practice who are 28 and their antral follicle count is 28 or 30. They have a ton of eggs, and I usually only have them see me once a week leading up, for a couple weeks leading up to retrieval. And then during the stim cycle, I'll have them come in sometimes 2, sometimes 3 if they want to come in a third time, or they're feeling really yucky, or they just want that extra emotional support. So I don't know where you fall on the spectrum of that, but it's you know, I think it's patient by patient.
Okay, we have time for 2 more questions. This one's for Dr. Danzer. How do fibroids affect the egg freezing process? Do you recommend shrinking or removing the fibroids prior to egg freezing?
Yeah, it depends on the position and the size of the fibroids. Most of the time you can get around the fibroids to retrieve the eggs. If they're really large, but that has to be individualized.
Okay, and then our last question. This person has a 2-part question. So, if you're doing a second cycle, should you stay on the same protocol or do something different? They had a consultation and the new doctor is suggesting a different protocol, even though they got good results from the first time.
You know, that's a very individual thing. I mean, uh, different doctors have different experiences with different protocols, and if you had a good experience with the first cycle, that most people stay with that, but that the physician really has to individualize it and give a reason why they think they would change it.
All right. Thank you everyone for joining today's webinar with Dr. Danzer and Dr. Shulman. We do have more questions and we typically do reels and TikTok videos, and our doctors record these videos answering your questions. So make sure you follow us on all of our social media to see more, and we'll see you in a couple weeks. All right.
Thank you all for coming this afternoon. And again, if you have other questions or want a consultation, we're certainly here to help you.
Have a great day. Bye.